All right, it is 6:30. We're going to go ahead and get started with our grand rounds here. We have Dr. Ehlers coming, and I'm going to have Dr. Wright present. So,
well, good morning. It is a real pleasure to invite Dr. Ehlers to be our visiting professor. For the more junior members of the department, you may not remember Annie, but she was a medical student and then a sub-I on the upper GI service with us, and then a resident. She spent 2 years in the source lab, and then she did our upper GI fellowship before going on to take really one of the best academic jobs in the country at the University of Michigan. As a perhaps inspiration to our residents, hopefully, she won the award at the Schilling competition for the best resident research, and won at the Harkins Award at the Washington State chapter of the American College of Surgeons, along a lot of other awards. I think the one that I'm most proud to see her achieve is the Career Development Award for SAGES, which is my home society, and really, I think, a reflection on her career as an early faculty. Her research is actually really interesting. Many years ago, we were sitting and doing a lap inguinal hernia on a woman, and we were talking about the fact that all of the data in groin hernias is about men. And she's actually used that discussion to launch a whole career, and actually has her K award to look at gender differences in inguinal hernia. And so a real honor and pleasure to invite her to talk about her early career research development, and hopefully give us all some advice. So.
Well, thank you so much. It's really exciting to be back here. I think since I graduated about 6 years, hoped for this opportunity. So thanks so much for hosting me. Yesterday I had a great day meeting with residents and fellows and faculty, both at Source and here at Montlake. So excited to share more. My only disclosures are some grant funding where I'll be discussing some results from these projects. So like Dr. Wright said, I think a lot of time people save their thank yous for the end, but this was truly, where I learned how to be a doctor, where I learned how to be a surgeon, where I learned how to do research. So it's really been one of the most transformative 12 years of my life, I will say. So it was a big time. Usually I think when I give a talk like this, it's pretty research heavy, and there's still going to be a lot of research, but I think every time that I have an opportunity to give a big talk, it's very much informed by the work that I'm doing at that time. And right now, the work that I'm doing is trying to go up for promotion. And so it's been a lot of reflection about like, well, what have I really been doing over the last 6 years? Like what's worked, what hasn't worked? It's going to be a little bit more along that line. Still a lot of research, but so with that in mind, I'm going to start with a story. This is a story actually that I heard a couple of months ago about labyrinths, and I was really intrigued by it. And there's labyrinths that have appeared in all sorts of, I think, ancient texts and stories. And the particular story that I heard was from ancient Greece, and it was about this labyrinth that housed a minotaur, which was half man, half beast. And every year, in order to kind of sate the minotaur and keep him in the labyrinth, they had to give human sacrifices, and it was just this terrible thing. Until one day, a young warrior named Theseus came along and said, "I'm going to slay the minotaur once and for all." And unfortunately, the woman guarding the labyrinth fell in love with him. And so she said, "I cannot let you go in there to die." And so she gave him not only a weapon, but as you can maybe see right here, a little red thread so that when he went into the labyrinth, he wouldn't get lost on his way out. And it was funny because when I heard this story, I think it's supposed to be kind of a metaphor for life. But for me, I was like, oh my God, this is academic surgery. And I talked to one of my partners who's kind of into stuff like this. And he's like, even before I mentioned what I thought, he was like, oh my God, that's like intern year, that's like residency. And so it seemed like a perfect way to kind of get into this. And for me, the labyrinth has always been academic medicine, but I think at different points along the way, and I was talking about this with, I think, one of the residents yesterday. It's like, as soon as you slay the first minotaur, there's like the next one. So, I think the first one for me was getting through intern year without crying every day. Then I had to find a fellowship and a job, and I really thought that like things would be much easier after that. But then I realized I had to develop a line of research so I could get funded, think about how am I going to build my service line, build my referrals, how am I going to get leadership opportunities, cultivate my national reputation. And I think now is promotion and advancement. I think there's tons of minotaurs, I'll say, that are not listed on this slide that I think, regardless of where you are at your career, whether you're a student, whether you're a very seasoned faculty member, there's always sort of that next thing that you're thinking about. But then again, I mentioned this red thread, and I think that was what really intrigued me about the story, is that there's something that is guiding you along. And I was a little worried that this was going to be a little bit too woo-woo or touchy-feely. But it turns out that this is something that's talked about in the business literature about finding what your red thread is, or the thing that really keeps you going. So this is a great book that actually one of my colleagues gave me, thinking about how do you really integrate what you like to do with what you have to do. And he specifically mentions red threads, which they're something of a different material. They appear to be extremely positively charged. You find yourself instinctively wanting to pull on those threads. And when you do, your life feels easier, more natural, time rushes by, and these threads are the source of your weird, your uniqueness, felt and then expressed in certain activities. And I think it's a tough thing to think about, especially when we're really busy and under a lot of pressure, but he actually gives kind of a tool to think about this. So if you want to figure out what that thing is for you, when was the last time you lost track of time, felt that you were really good at something without trying, you really didn't want that activity to end? And for me, when I read this, I was like, oh yeah, it was last week when I was at my research lab and we had like 2 hours to just talk about our projects and our grants, and it just went by super quickly. And I think it's no surprise for people who know me that my red thread is health services research, which is something that I really learned about and cultivated here. I think yesterday, Dr. Flum asked me like to talk about how I got interested in research. And I think, or I know, when I came into residency, I had never written a paper before, maybe had written one abstract. I really had no clue how to do this, but over a couple years of working with the source faculty and learning how to start a big trial from start to finish, it really made me realize that this was the thing for me. And so again, getting back to what I've been working on the last 6 years is really understanding how to be successful as a faculty member, when obviously, I really like this research part, but I have to demonstrate excellence in other areas. And I think this is a big challenge for us, as people say like, well, I really like operating, but I don't know if I like the research part, or I really like teaching, but clinical operations not really my thing. But as we all know, you can't always do just the one thing that you want. So thinking about how I've used the thing that I like to help me check all the boxes in a way that is meaningful and satisfying. So I'm going to go through each of these and kind of give some examples of how I've been able to infuse what I've done to hopefully also give back to my institution, give back to surgery as a whole. I'll start with research, which is obviously arguably the easiest one for me. But even with that has been a big journey. So when I left the University of Washington in 2019, I moved across the country. I think on the day that I started my job, I had like a 3-month-old baby. I was in a brand new city trying to figure out how to be a faculty member. And also 6 months later, it was COVID. And so it was just like the most disorienting time. And at the same time, I knew that I still had this big task to complete, whether or not the circumstances aligned for me. And one of the things that really kept me grounded, particularly during those early days of the pandemic, were thinking like, what do I know how to do? I know how to do some research. And so after a lot of back and forth with one of my mentors, we thought, what's kind of a low-hanging fruit project that I can get started on that, can get me learning about some of the databases that we have in Michigan, get me started with some of the analysts. And so this was one of the first big projects that I did. And it was using one of our statewide databases that allows you to look not only at sort of what happens around the time of surgery, but where do people go after, and follow them for a while. And our question was, how often are people using services like physical therapy, going to a SNF after having common elective operations? So lap chole, ventral hernia repair, inguinal hernia repair. And I think not surprisingly, it was pretty unusual, single digits. Fortunately, not a lot of people needed that. But one of our key findings from that investigation was that for some reason, for both inguinal and ventral hernia, women were significantly more likely to need those services. And, clearly from this one study and claims, we couldn't explain that. But I think, in addition to some of these questions I had already come in with from my training, it really led me down my first line of investigation. And it turned out when we looked further, females have worse outcomes, not just for inguinal hernia repair, but for ventral hernia too. So when we looked at some of the data we have from our hernia registry, which I'll talk about in a little bit, we found that females were more likely to experience complications in the 30 days after surgery. And that, you can see the blue shaded areas for men, their risk of complications really stayed the same across all hernia sizes, even after adjusting for important comorbidities, operative details. But for females, that was not true. And we saw a stepwise progression in risk of complications. And even when we looked at some of our patient-reported outcomes up to a year after surgery, females were often more likely to express chronic pain, decision regret, self-reported hernia recurrence. And so, there's on the surface, there's really no reason for these outcomes. But again, kept digging. And my main conclusion from this was that there's probably, in addition to some unmeasured social factors, some two areas where we could really intervene and perhaps make a difference for this problem. So the first thing I noticed was that there's a really huge lack of high quality evidence for this population. As many people know, not just for hernia, but for things like cardiovascular disease, a lot of the big diseases that we study in medicine, many of the pivotal clinical trials that were done were performed in men. And so the outcomes we then apply to women, and not surprisingly, they do worse. And we don't know exactly why that is, but it's a real phenomenon that's true across many specialties. And the second thing I noted was that even when we might have some good data, there was sort of this lack of consideration on the part of surgeons about how to incorporate that into their care. So just looking first at the lack of high quality evidence, this was some early work that I did for my career development award, where I said, okay, if I'm going to study inguinal hernias in women, let's see what's been done so far, what's known about this problem, what's not. And so these are some of the critical trials that we look at in terms of how do we treat inguinal hernias, what approach should we use. And when you look across these, there was really no women that were included in any of these studies. So only one study that was looking at approach included any at all. And even for this, they were underrepresented because we know that females probably make up closer to 10% of people that are getting inguinal hernia repairs. And it turns out that, things like approach probably matter greatly. This was another study that I did early on looking at long-term outcomes in Medicare, so out to 10 years, kind of a more contemporary analysis of who's recurring after surgery. And you can see, first of all, we're doing pretty good. Most people, when we look out to 5 years, very low risk of recurrence, less than 4%. But these lower bars here show that women who get MIS repair have the least likely chance of recurring. And so something we might be able to intervene upon. So thinking about this, then my next question was like, okay, if there is maybe some data that our findings were also corroborated by a lot of great registry studies in Europe, what do the guidelines say? And are we actually following those guidelines? So if we do have some data, are we using that in the best way to care for our patients? So for inguinal or groin hernia, as I mentioned, we should be considering minimally invasive technique, not just for things like recurrence, but we think it leads to lower risk of chronic pain and other negative patient-reported outcomes. And then getting back to ventral hernia, the first example that I gave, thinking about women of childbearing age, and should we be using mesh in all hernia repairs? So I first tackled the inguinal hernia question. I looked at this both in one of our statewide databases to see what are practice patterns like in Michigan, but then also more globally in a Medicare population. And I found that most females undergo an open groin hernia repair, so guideline discordant care. And again, I'm not thinking that 100% of females should have this treatment, but certainly more than 63%. And there's a lot of reasons for this. I think a prime one being that not all surgeons know how to do an MIS hernia repair. And so the students always ask, how do you select what type of hernia repair to do? And the first thing I say is like, well, it's kind of what your surgeon knows how to do and likes what to do, because they're probably not going to send you down the street if they don't know how to do that type. And then the second question is, what are we doing with women of childbearing age? Or are we thinking about that at all when we're caring for them? This was a study that actually one of our residents did, looking at use of mesh placement for ventral hernia repair. And our hypothesis was that maybe mesh use would be lower among women of childbearing age, so in that sort of 20, 30s age. And as women got older, you might see more mesh placement if people were following the guidelines. And in fact, we really did not see that was the case. So how did we try to understand that phenomenon? It's always really challenging with claims. And I think probably some of the residents that I met with yesterday at Source heard me say this, but I think it's always a really good idea to go back to who's your stakeholder, who's doing this, and do a really great qualitative study. This was kind of a sub-analysis of one of my favorite projects that actually my mentor was doing right when I started, where she interviewed a lot of surgeons around Michigan to really get a deep dive into their practice patterns, how they think about guidelines. And we had some specific questions around how do you treat women of childbearing age differently, if at all? And these were two of the exemplary quotes that basically said they don't really consider it, because how am I supposed to tell if someone's gonna get pregnant or not, or I'm just gonna do the best thing that I think is at the time without considering that. And so getting back to this really made me realize, if we're gonna improve care for this large population of people that's getting ventral hernia repair, we probably need not only better data, but also presented in a compelling way that surgeons will actually adopt. And this, as Dr. Wright said, is what ultimately led me to my K Award, which is focused on developing the background data and infrastructure to hopefully run a trial, which Dr. Flum says I shouldn't do. So we'll have to talk about that later, some more trauma to unpack. But so we'll see if I ever do that. But no, I'm joking, but this was a lot of years of work where my goal is ultimately to develop some additional data, get the infrastructure, get surgeons on board, get patients on board to develop a watchful waiting trial for women. And we've already started to do some of this work. This was a study that I mentored a medical student on recently, where we interviewed women, I think 35 of them, who had already had an inguinal hernia repair, to understand what their experience was like, what they would like to see in research in the future. And it was super interesting, but I think one theme that I was really happy that came out is there were a lot of questions about, why is it when I go to Amazon to buy a hernia truss, they're all for men? Why are there none for women? And how is it that my doctor, had seen me with this problem for 5 years and didn't know about it? And excitingly for us, we did ask, would you think about participating in a study if you were randomly assigned to one treatment or the other? And more than half of people said yes or maybe, which leads us to hopefully believe that this may be a successful endeavor in the future. So switching gears a little bit to teaching, I think in an academic medical center, we all know that sort of the bare minimum is performing excellent clinical care, but teaching is a huge component of that, because that's really one of our primary missions. And I'll say this was never really my forte as a resident and junior faculty member. I wasn't really ever the person that was doing chalk talks, and it just wasn't what I would say my strength. And so it's something that I've really focused on early on. And I think still these days, I'm not the person giving chalk talks, but as I was thinking about how can I put my own stamp on teaching, it really came down to how can I translate my love of health services research in a way to residents that will help them, regardless of whether or not they're going to choose a career in research in the future, but to set them up for success in academic medicine. And I think in surgery, one of the key things that comes out when we're teaching any resident how to do things, or at least what I think about, is understanding sort of the what we're doing versus the how we're doing it. So this is a picture of a sleeve gastrectomy, an operation that I do not as much as I used to, unfortunately, but one of the most common operations that I do. And I always have a resident there with me. And I think the reality is that while I want to teach them how to do a sleeve gastrectomy, most of them are never going to become bariatric surgeons. They'll probably never do this case again after they graduate. And so what can I actually teach them that they'll bring with them? And so just one example, particularly for a newer resident, learning, this is a great case to use to learn to use a stapler. So how do you grasp it? How do you position it relative to the tissue? In a way that even if they never do a sleeve gastrectomy, I've taught them a skill. And I think this is true for pretty much every operation that we could perform, is sending the resident home with a translatable skill that they'll keep with them. And in research, I think there's actually a lot of those same fundamentals. And so I think when everyone thinks about research, and I certainly did to begin with, it's really like, oh, you're doing a project, you're crunching some numbers, you're writing a paper, and that's what it is. But there's actually, I think, a huge how behind how you do that and what skills you can take from that. And so one of the big things that I have learned, and this paper that I'm showing here, is really understanding that it's not just crunching those numbers, but it's telling the story in a compelling way that is going to entice that journal to publish your manuscript or that funder to accept your grant. But again, I think this is a skill that if you can learn how to do this, you can translate it to any part of your career. So going to your chairperson to ask for some funding for a new service line, or working with your, whatever committee you're on at the hospital to get something done. It's really understanding how do you tell that story in a way that makes people want to get on board with you. And so the way that we teach this to residents is, this is just an example. I borrowed this slide from one of my colleagues who has just a really amazing way of teaching residents how to write. But, when you're thinking about your introduction, it's got to be 3 paragraphs. You're giving context to the problem, creating a knowledge gap to get people curious, and then giving a mini work plan. And again, I think whether or not you ever choose to write a paper again, if you can have this framework in your mind, it can really help you in many other areas of your career as you go on. And my favorite place to implement this and teach is our lab. We call ourselves the Core Lab, which is the Core Optimization Hernia Registry. And just a little background for most of you who are probably not familiar, Michigan has a really unique payment structure where Blue Cross Blue Shield covers most of the lives in Michigan. And so they have a really vested interest in population health. And as a result, they've developed all of what we call continuous quality improvement collaboratives. There's one for urology, cancer, diabetes, social determinants of health, and there's one for general surgery. And right when I was starting, my mentor actually branched off and started one around hernia repair, because we know that this has always been a really challenging disease to study. And so in addition to sort of general comorbidities, patient demographics, we're able to study things like hernia size, whether or not mesh was used, where that mesh was placed, how it was affixed. We can look at 30-day outcomes, but we're also increasingly, we have more than 3,000 long-term outcomes at this point. So it's been really exciting. And I think the best part of that is using this sort of the what to teach the how to residents. And we have a pretty, I think, again, getting back to this idea, this is how people think of the process, is that, you are taking this story start to finish, but it's really this graduated process that we try to implement with our residents, again, to teach them just as you would in surgery. All right, today we're learning how to do the ports. Maybe next time you'll learn how to fire the stapler. It's the same thing. And I think this is certainly how I learned how to do research. My first projects were ones where the analysis had been done, there was tables and figures, and it was really me just having to focus on writing the paper, versus now when I'm sort of thinking of this whole process. And so again, this has been one of the things that me and my research mentor are most proud of, because when we started this lab in 2020, it was literally 2 faculty members and I think a resident and a student. And over 5 years, we've grown to have more than 40 faculty, resident, students, not just from surgery, but we have undergrads, we have people from School of Public Health. One of our prior lab managers is now getting his PhD. We have been really successful with manuscripts, publishing, but I think just really the best part has been promoting our students and our residents to really get to that next level. And then the third thing I'll talk about is service, which is arguably, I think, can be one of the most challenging and tedious parts of our job, but we all know that in order to keep the department running, the hospital running, the societies, we all have to kind of do our part. And I think when I started my job, my boss was like, well, I hate doing committees, so I never do that and whatever. But I probably couldn't get away with that as a junior faculty member. So thinking about it again, how do I integrate what I really like to do in a way that not only helps my community and my department, but makes me feel fulfilled also. So not surprisingly, I've done this in hernia, and I'm just going to backtrack a little bit. You've heard me talk a lot about abdominal wall hernia. And I think we get the question all the time, like, who cares? Like, why are you even studying hernia? I actually had one of my colleagues tell it to my face like a couple weeks ago, like, that work is just not interesting. Why are you doing it? But it's really important, I think, to me and to millions of people who have this operation every year. It's one of the most common operations that we do. It's very costly to our healthcare system, and there's, a high risk of adverse events. And I would argue it's also a place where we've seen a lot of change and innovation over the last few years, which unfortunately has led to some challenging problems. This was an investigative journalism piece that came out in the New York Times about a year and a half ago, where they used a lot of data from our lab, as well as some national trends to show that, some of the trends that we're seeing with adoption of robotics and newer advanced techniques in component separation, that if they're not learned and adopted in a proper fashion, it can lead to real patient harm. And again, you might say, like, who cares about hernia? But I think it's a great case example where we can really study things like this in a nuanced way, because hernia is not the only place where technique changes, adoption of new technology. And so it's allowed us to have a little micro lab of studying this in a disease where you often do have time to wait. You do have choices about what operation to perform and when to perform it. And I think the really important thing is that even with all these changes and, we didn't used to use mesh and we didn't have laparoscopy, and we've had a lot of changes, that the outcomes have not improved over time. So this is a study that actually Dr. Flum published like 20 or 25 years ago using data from Washington State. And for a really long time, this was the only paper that was out there to talk about long-term hernia recurrence. And so every paper cited this. And so we really wanted to know, well, this study was published 20 years ago. People weren't doing laparoscopic repair as much back then. Use of mesh wasn't as common. Surely outcomes have gotten better with that. And they really haven't. So this was one of our first big papers. It was actually published in JAMA. And we looked at 10-year recurrence rates. And you can see that those curves are identical, and that we're still seeing recurrence rates. And this is just operative recurrence. This doesn't include people that recur and do not have a reoperation, which could be as much as, I think, 2 times as high as this. But really, we haven't gotten better over time. And so unpacking why it is at a population level. One of the challenges that existed and still exists to a certain extent is that prior to 2023, where there was some coding changes that I'll talk about, there was really only a handful of codes to describe ventral hernias. And even in Medicare, this was always our big problem. You could never know how big a hernia was, exactly where it was. So these 3 hernias, you have a very simple umbilical hernia, a larger, probably incisional hernia, peristomal. You didn't know if you were comparing apples to apples and what you were really looking at. In 2023, they did make some changes. You can see these are the new codes where we now do have some information about how large a hernia is, whether it was reducible or not. But in some ways, they actually made it worse, because now we're not able to track if people had a laparoscopic repair, an open repair, whether or not mesh was used. So it's a really messy problem to study. And this was exactly one of the reasons why we developed this registry that I talked a little bit before, is to get a more granular view at a population level of what's going on and how can we really move the needle to improve outcomes for this really large population of people. This is certainly not the first registry of its kind. We actually based most of our variables after the registry that the American Hernia Society has, which is the, I always forget the acronym, but it's collects very similar variables from around the country. And it's a really great resource. And at the same time, the challenge has always been that it requires a big lift from surgeons. So it requires surgeons to input their own data. Many of the surgeons that participate are from these really highly skilled hernia centers. So maybe their patients are not representative of the average patient. And honestly, perhaps their skill level is probably more advanced than the common general surgeon performing ventral hernia repairs. One of the big differences with our registry and what we were really excited about is, as I mentioned before, we had this opportunity to leverage an existing resource in our state to kind of piggyback on that. We said these hospitals already have abstractors there. They already have the data collection infrastructure. So how can we add things? And so it's hard to see, but we added things like location, size, what brand of mesh was used. And it actually got rolled out in a pretty systematic fashion that included a synoptic operative report to help make sure that surgeons were actually recording these things in their operative note, so that it could be collected in a rigorous way. And I showed you this slide before, but just again, thinking back, in 5 years, we've been able to collect short-term outcomes for more than 20,000 patients, nearly 700 surgeons from a very diverse group of hospitals across the state. And then we're increasingly collecting long-term follow-up data. So again, getting back to the service piece of this, the main goal of this was to improve population health and improve outcomes for hernia repair. And I think with hernia repair, as with many other diseases, there's kind of a couple points you can intervene. And so we wanted to start with the low-hanging fruit first, which is how do we make sure that when we're doing the operation, we're performing the operation on the right person at the right time. And it really came down to a question of adherence to preoperative optimization strategies. We talked about this a little bit in the roundtable yesterday, but one of the big pushes that's been going on for a while now is to try to avoid performing elective surgery when you can on persons who are actively smoking or have a BMI certainly greater than 40 and greater than 35 in some cases. And so one of the first things we did was say, okay, what's the current state in Michigan? And this is just showing levels of non-adherence across all the hospitals that did hernia repairs at that time. And you can see that some sites are doing pretty well. Most of their patients are optimized. But as we get further along, nearly half of sites, half of their patients either have high BMI or are actively smoking at the time of surgery. And it was really sort of an easy way to get into this problem, we thought, because most surgeons will agree that it's probably a good idea to optimize people before surgery. We did a little more digging just to really point this out and saw that, with these, again, 25% of people on average were not optimized. And this led to significant increases in not only complications, but also spending per episode of care. So trying to think of what people cared about. And again, I shared a little from this qualitative study earlier, but this was sort of the broader questions of asking surgeons, why don't you do these things? It seems like pretty common sense to implement these. And we used an implementation framework called the Theoretical Domains Framework, where you essentially design your interview guide in a way that's going to allow you to categorize the responses so that you can apply evidence-based or theory-based interventions to address them. So after going through this and coding everything, we found that there were 3 main barriers or reasons that surgeons did not adhere to guidelines. It was financial, so loss of income, a big thing. People said, I don't get paid not to operate. If I don't operate on this person, they're going to go down the street to the other surgeon and they're going to do that operation. So I can't not operate. One was knowledge and resource access. So I think at big places like University of Washington, University of Michigan, we have a lot of resources if you want someone to lose weight or quit smoking. But again, a lot of these people are practicing at small sites in rural Michigan. They don't have a preoperative clinic. So how are they gonna, what resources do they even have if they want to do this? And then the third was practice patterns and organizational barriers. So yeah, I'd like to do that, but this is just the way we do it. This is what my senior partner says. And again, we were able to use those responses to think about what would be a theory-based strategy to address them. And this has really been, this rolled into a grant that my mentor had funded a couple of years ago that I work really closely with her on. And essentially what we did was we developed a couple interventions that have been part of a SMART trial to look at how can we implement these in a way that's both effective at addressing the needs of that site, but also scales up and scales down. So as all of you know, different hospitals, different providers, it's not one size fits all. So thinking about how do we do this in a way that will help. And what we've done is worked with one of our implementation scientists to develop what's called a replicating effective practice framework. And this is a pretty commonly described implementation framework that's mostly been applied so far in kind of outpatient. They've used it in schools, they've used it in the mental health setting, but it has very rarely, if ever, been applied to a surgical population. And what you think about is developing a package that can ideally be scaled across sites that's resource or low resource burden, but that can be picked up at many places and adapted to the needs of that site to help them do the thing that you're asking them to do, which in this case was adhere to preoperative optimization guidelines. This resulted in what we call the heroic package, and the website's there if you want to check it out, but it's essentially a toolbox of really short videos where we, used opinion leaders from around the state to try to address that practice conformity, knowledge. So thinking about, okay, what's the data out there? And then also providing resources that they can access, even if they don't have those resources at their site. And then it comes along with some self-assessment. Did they learn what we were hoping for them to learn? And I think, again, a big thing has been addressing knowledge and resources. So these are avatars of some of our leaders in MSQC where they're talking about this. We're interviewing surgeons from different sites. But a main piece of this has been developing a risk calculator, because one of the key pieces of feedback we get from surgeons even now is, I know this, but the patients don't understand this. They come to me to get their hernia fixed. They didn't come here. They know they shouldn't be smoking. They didn't come here to talk about their weight. And so how are we able to communicate this risk in a way that resonates with patients? And this is our calculator, which I was really happy to see that someone pulled it up for our case presentations yesterday. It's publicly available, and it was developed based on all of those 20,000 plus patients that we've collected short and long-term data on in our state. And we're continually updating it. It's still pretty early on, so not perfect yet. But the idea is it's a tool that you can use in the clinic with your patient to say, your risk right now, if at your current weight or your current level of smoking, integrating the size of your hernia, what planned approach we're going to take is here. So for this patient, pretty high 60th percentile. If you can lose weight, we can really take that down. So a visual cue to patients. And I think what's even more exciting, and I apologize that the color is sort of muted here, but this is looking at the self-perceived recurrence. It's not just complications. Most people say, well, the complications are so low after this, is the death and destruction what we really should be targeting? And so we've really focused on looking at this long-term hernia recurrence, because it is, at the end of the day, for most patients, a quality of life operation. And so we should probably be measuring its success with quality of life outcomes. So that's what we've been working on to target that operative optimization. And again, we targeted that first because we thought it would be low-hanging fruit, something that people could get on board with. Now that we have people a little bit more engaged, our next book of business is really thinking about what happens in the operating room, which I think has really been a black box for hernia for a long time. So as I showed previously, there's never been a good way to look at this in terms of approach, hernia size, et cetera. So the next thing we're looking at is going to be adherence to evidence-based guidelines across our sites in the operating room. And again, for hernia repair, given the challenges that I've showed, there are not a lot of really high level pieces of evidence, but there are a few. So I'd say one of the best pieces of evidence that most surgeons will agree on is that for hernias larger than 2 centimeters, sometimes larger than 1 centimeter, we should be using a permanent mesh to help reduce that risk of recurrence, which we know is fairly high. And so again, looking at these guidelines that are, high quality of evidence, strong recommendation, what's happening across our state. And in fact, when we looked across the state, even after adjusting for approach, number of cases that they did, we again saw that some hospitals were using mesh 40% of the time, and some hospitals using it 100% of the time. And so again, a really good opportunity for quality improvement interventions. And again, we were able to go back to that same qualitative study to hone in on, because it's the same thing, right? Why are you not following these guidelines? And as we poured through that data a little bit more, some other themes that came out were that it's often hard for people to incorporate guidelines when they don't feel like it's based on their patients. So if the guidelines were made based on randomized controlled trials at big centers, a lot of people say, those are not my patients. This does not represent my patient population. I think they also can be seen kind of as blanket statements without attention to the challenges that are faced at each site. And we don't incorporate the views of different surgeons when we're doing that. So to address this, one of the first things we did was in the fall, we actually hosted our first ever annual hernia summit, which was super, super fun. It was a 3 or 4 hour event that we had with surgeons from across the state. So we had more than 50 surgeons, data abstractors, nurses. And really what we did for several hours was to do some case presentations and talk about different scenarios in hernia care to hear from people. What do you think we should do? What's most appropriate? Again, with an eye towards thinking about what are these first levers that we should pull to try to improve adherence in the operating room. And we used what we called a modified Delphi process, which it's a pretty broad term, but it's basically a way of bringing providers together to get best evidence where there's scant evidence. So best opinion combined with the evidence. And we asked a lot of different questions around, all right, do you agree that synthetic mesh should be used for all hernias bigger than 2 centimeters? Most people agree. A lot more controversy when we looked at the smaller hernias. Same thing with when we asked about clean contaminated and clean hernia cases. I think the component separation question was a little bit easier to address. But after our conversation, these were some of, I think, the first key areas that we thought would be good areas to address given the relative strength of evidence as well as the controversy that exists in the field. And so to approach this is a schema from a grant that was reviewed in the fall that got fairly good scores. That's actually going to get re-reviewed in a couple of weeks. And our goal is to, again, use a similar replicating effective practice framework, building on our initial modules around preoperative optimization to look at how do we implement guidelines for operative practice across heterogeneous sites and surgeons. And so that's hopefully what will be coming in the next coming years. And I think that's the end of the talk today. So kind of coming back full circle, I think, hopefully I've given a little bit of insight into both what I've been working with over the last few years, but also, I really used my love of research as kind of the red thread or the grounding force here. But I think the challenge is for all of us to think about what is the thing that you like to do and how can you apply that to all of the stuff that we have to do in academic medicine. So huge thanks to our team. You probably saw that a lot of the data that I presented today was not even something that was my first author work. We work super collaboratively together, and it's just a really great group of people. So could not do this without the team. With that, I think time for some questions. So, hi.
For you. Thank you for the talk. And what is very relevant to my practice. So, I have 2 questions. The first of which is, did you, especially in the rural sites and their access to like optimization, have you seen any changes in their access to that after COVID with the implementation of more telemedicine opportunities to engage maybe with primary care providers or other support persons that can do things around optimization?
We have not, and we actually looked at, particularly for smoking, we've looked at a couple different things. One of the first strategies we used across the state was can we incent surgeons to do this even where they don't have access, like pay them to give that counseling in the office perhaps? Because when we look, I think as you mentioned, the first thing most of us say is like, okay, you got to quit smoking, go to your PCP and ask them for help. And I didn't present this work here, but a lot of patients don't have a PCP or they don't have time to get to one. And so we've been thinking about how can we offer those resources in the surgery clinic itself, because it's just not feasible, I think, to tell patients to go figure it out on their own.
My next question is, I think more relevant to right now, this is probably gonna be something that we'll see more out of your research collaborative over the next year or so. But with the changes in Medicare and Medicaid funding, how do you think that have you seen any preliminary impacts on how these surgeries are being performed out in the community where the reimbursement may not necessarily exist as much before? And how do you foresee that impacting repair surgeries?
Yeah, we haven't, I think it's still pretty early on. I think the thing that we always worry about is what's going to happen to these people that delay and wait on their hernia care. I think fortunately, for most patients, the risk, and this is, again, if you talk to our EGS colleagues, they'll be like, you have no idea what you're talking about. But the data would suggest that the risk of an incarceration event requiring emergency surgery is pretty low. That being said, it can be a really debilitating thing for patients. So I think that is still to be determined. We do know, though, that the changes to payment do have an impact. So one of our, he's now a PhD candidate who's been our program manager for a long time, did an early analysis, like an interrupted time series analysis, looking at documented hernia size in our registry before and after those 2023 coding changes. And interestingly, our average hernia size went from 2.5 centimeters to 3 centimeters in a 1 month time frame. Which if you recall, the 3 centimeter hernia size is what Medicare will pay more for now. So I think to that point, yes, whatever the policies are certainly will have an impact on how our surgeons practice, but it's probably just a little too early to know exactly what that will be.
And Dr. Clark, I think a great example of how you can follow your passion and really make impactful change. I have only 2 questions for you. One is around the outcome metric of self-reported recurrence, which I think is great because that is what the patients care about. But I'm curious because we see this now in the commonly, so we think I have a right to image of the no recurrence. What proportion of people who believe they have a recurrence actually have a recurrence? Do you know that? And what factors can we do to better counsel them? As to, there might be some soft tissue that's uneven, but that doesn't mean have a recurrence.
Yeah, I think couple things to unpack there. There is a debate, like, does it matter if they think they have a hernia recurrence if they don't actually have one? I would argue yes, because you were trying to fix a bulge or something that bothered them. And if you haven't fixed that, then your operation was in some ways unsuccessful. We really are trying to triangulate like that 4x4 box of like, yes, you have a hernia. No, you don't. Who's reporting it and who isn't? I think we're starting to get there. The challenges with the registry, we have 30-day clinical outcome data and 1-year patient-reported outcome data, but that long-term clinical outcome data is lacking. So we're right now trying to merge it with some other sources of data to get at that source of truth, like how many of these people actually had a recurrent operation. And so I think that's going to take us a little bit longer to tease out. And then I think to your third question about counseling, that's one of the reasons I think we've really tried to push, not just looking at the 30-day outcomes with our risk calculator, but counseling the patient and also thinking about like, what is really bothering them? Is it the 1 centimeter hernia, or is it the huge diastasis that every time they sit up, they think they have a football on their abdomen? And so if you're not really getting at that, what is it that bothers the patients and saying, this is what I can fix, this is what I can't fix, I think you're never really going to get that result that you want.
And the second question, just balancing preoperative optimization with a patient who says it's preparing their ability to work. So a lot of my patients are heavy laborers, construction workers, right? And they're not able, they feel like they're not able to fully work at their job, or they're not able to get employed because of this hernia. And so they're very anxious to get it fixed. And they're still, or they're hoping. So what, kind of in surveying patients or assessing patients' risk, how do you balance in that need for income, which is critical to their quality of life as well?
Yeah, it's a huge challenge. And as some of you know, I practice at the VA, so similar patient population. A lot of people are smoking. People, really need to work to be able to live. And I think it's a balance. So when I think about how many people should be optimized, hopefully most patients. So, 70, 75% of people. There's persons that we don't optimize. So if they're coming back with recurrent incarceration events, that person needs to get their hernia fixed, right? Because they've shown us, they've proven to us that they have a high risk hernia. I also think that's something to keep in consideration is if someone literally can't live their life, you may think about it a little bit differently. A strategy that I sometimes use is I'll talk to the patient, give them as much data as I can and say, let's come back in short-term follow-up, 3 months, and see how things are going with smoking or weight loss. Give them some time to think about it, maybe try some different things. And if not, I certainly have taken people to the operating room who are smoking or who have high BMI for those exact reasons. We've done qualitative work with patients who were in an optimization clinic, and they're basically like, I don't know how you expect me to live with this. Like, I can't take care of my kids. It looks like I'm pregnant all the time. And so I think we're increasingly noting the significant impact it has on patients and taking that into consideration.
And congratulations, that was an amazing talk. And also on like a firecracker started for there 6 years, done so much, and it's everything from primary research to the applied work to the public health work. It's really a fantastic work. Thanks, a great example for everybody to see. And thank you for validating that study in Washington State.
That's right.
For years, Washington State surgeons have been thinking that I was making them look bad.
No.
Now they know we're just all equal.
Everyone's bad. Yeah.
But I have a question for you about what you're thinking about the sex differences in hernia and what is sex a biological variable, as we've been sort of programmed to at least interrogate in our research? And if so, what are your hypotheses about why women may be doing worse with hernia surgery, and if it's a biological variable or not? Just that they were under-tested.
Yeah, so I think for inguinal hernia, it's pretty straightforward. I think it's that we often do the wrong operation. Inguinal hernia, I think there's fewer variables, but if most women are getting an open operation when we should be doing MIS, and frankly, perhaps we're doing operations on people that don't need it. So I think that's a pretty cut and dry. With the ventral hernia, it's really something that we have been trying to unpack, and I still think have a lot of work to do. Some of the hypotheses that we've had are, are there differences in the shape of the abdominal wall, the way that weight is distributed? We know some of our colleagues that do work in trauma that really the way that your body is contoured can change risk for hernia recovery. Other hypotheses that we've had is this issue of diastasis. So are women coming, they have a big diastasis and an umbilical hernia that perhaps they developed after several pregnancies, and we're just fixing the one, not fixing the other. So perhaps it's that. We also know from a lot of our studies, women tend to have surgery, or women tend to be less often optimized at the time they have surgery. And so we see more women getting surgery when they're smoking or have high BMI. And again, it's unclear, is that because who knows why that is, but they also tend to have bigger hernias. So are we pushing it out longer? Are we waiting longer? And I think another thing we think about is, at least when I do a hernia repair, I really tell people to take it easy for a month and a half. And if you're a woman with kids at home, or women tend to have more caretaking responsibilities, are you really able to comply with those post-operative requests that we're giving? And so I think, we actually have a lot of students that are interested in this, and I think it's TBD, so.
Fantastic talk, and super happy to be back here with us. You talked a lot about the power of mentorship, and yesterday at the resident roundtable, I think that was the number one topic was when you're looking for a fellowship, when you're looking for your first job, how do you find those mentors? So I was hoping you could touch on that for the bigger audience.
Yeah, it's a great question. When I started my job, there was, I think even in my contract or whatever, this is going to be your clinical mentor and this is going to be your research mentor. And by the time I actually got there, there had been a lot of changes. And so that research mentor was not really available. And so I did have to actually figure out like who's going to be my person. And I think it did take a while of sort of like meeting with different people and understanding who had shared interests. I mean, I think for me, it was ultimately a combination of luck and also shared interest. So my primary research mentor is Dana Tellem, and she's just supported me so much. She, I think in one of my first months as faculty, excuse me, it was kind of clear that I was struggling a little bit, couldn't find my way. And she's like, hey, I'll meet with you every Friday. Let's just, suss out some ideas. And it didn't start out as like, we're going to do our research together for the next 5 years and have this really tight knit relationship. But I think, I was lucky for someone to take a chance on me. And also I kind of took a chance on, she was doing some stuff or some work that wasn't at that time my primary interest. I came in thinking I was going to look at referrals to bariatric surgery and sort of unpacking some of those access issues. And so I think it took flexibility on my end too, to think about like, what are sort of the meta issues that I want to think about? And is there maybe another opportunity to get into that versus the one that I thought I was coming with?
I have a couple Zoom here. So first a comment from Dr. Brackenridge. Congratulations on navigating the academic labyrinth. Great lessons for both trainees and faculty. And then I have a question from Dr. Peterson. Fabulous talk. Thank you for
Thank you.
sharing your journey. Agree, so many lessons that benefit us all. Question, the Michigan Registry database is so successful and lightens the lift on surgeons, which is the biggest problem for the ACHQC and us at UW to getting our data entered. How did you train and compensate the abstractors at the many sites to collect granular data such as hernia size, mesh position, et cetera?
Yeah, so this was, I mean, I think the easy part about that is all of those sites already had abstractors. And this is something that I think a lot of places are like, well, we don't have abstractors. And a lot of places do have abstractors, actually, if you participate in NISQIP or MBSA QIP or any of these more nationally, there are abstractors at each place. And so I think one is sort of thinking about how you can creatively leverage the resources you already have. When we first rolled this out, compliance and complete data entry was actually very low. And so we had a lot of missingness. We still do. And the abstractors are pretty smart. I think, of course, you have to say, like, this is the thing that we're looking for. And the abstractors, it turned out, were really the key to getting the project done, which sounds obvious, but they were the ones that were able to go back to their surgeons and say, like, hey, they're asking us to record these things and you're not putting them in your note. And I think it's a testament to sort of stakeholder engagement. We always think about the surgeon as the end user, but really anytime you're trying to do these sort of larger quality improvement interventions, you need to think about kind of the whole team that's doing it.
Thanks so much for that talk. I agree with that's like fantastic. I have a quick question about kind of the shop in general and kind of the editorial oversight that goes into things. And so specifically like the paper that you were referencing where essentially I'm just saying the surgeon are upcoding. Is that something where the members were involved in the decision to publish that paper? Have you had any backlash from the participating sites? And how does that decision get made? Or is it just a unilateral one Michigan's going to put out something that might eventually hurt surgeons?
It is a great question. It's a constant struggle, right? So we kind of jokingly say, like, we've got church and state, we've got the quality improvement arm of it, and also the research part of it. And I think we certainly do publish things that surgeons don't like, but on the other hand, this is a public resource. So we have invited surgeons to come in, and if they want, we have surgeons from other hospitals that join our weekly research meeting. And so it's not really a closed group in that way. There's triannual meetings where we talk about the projects that we're working on, what our next quality improvement steps are. And I think particularly like that, yeah, that was kind of a spicy paper. It actually got published in JAMA because I think it's not just, we framed it, I think, in kind of a clever way, which it wasn't like, look, these surgeons in Michigan are really gaming the system, but like from a more policy standpoint, what happens when you change policy about how things are coded? Because that is certainly not a problem specific to hernia care. And so it was, I think, framed in more of a way to not say, oh, we're doing a bad job, but look, this is human nature, that if you change the way the data is collected, it's probably going to change the way that people report it.
Thanks so much, Dr. Ehlers.
Thank you.